Okay, hello everyone. Welcome you all to Pain 2021 lecture series. Today, I'd like to introduce Professor Yodong Song from Bundang Seoul National University Hospital. Dr. Yodong Song has been trained in Seoul National University, and he has been dedicated to nuclear medicine, and especially for neuroimaging for nuclear medicine. So today he will deliver us a lecture regarding it. So please welcome Dr. Yosong Song.
화면 보이시나요? 공유가 되나요?
네, 잘 보입니다.
Okay, hello everyone. My name is Yusong Song from Seoul National University Bundang Hospital. Though it is by online, it's a pleasure to meet you. Thanks to Professor Lee for providing the opportunity. I see several familiar names on the list, and nice to meet you, though it's online. The topic I'm going to talk about today is about cerebrovascular diseases and epilepsy. Compared to other topics you have heard previously in this time, these two topics, cerebrovascular diseases regarding blood perfusions of the brain and epilepsy, are relatively an old section in the nuclear medicine, and the recent updates are rather slow compared with the other topics that you have heard. Also, as you might know, though, the populations of today's people are quite diverse. I will try to explain in an easy way. In our department, the volume of the imaging studies in both cerebrovascular diseases and epilepsy have been decreasing and going down compared with other CT or MRI modalities. It may be due to the rather long time for image acquisition, but also as a factor to do with slow updates. However, I'll try to review the past and present issues for the next 1 or 2 hours. If you have any comments or questions during the presentation, please don't bother to ask in the middle of the talk. As you all know, as quantification is the special characteristic point of nuclear medicine imaging, it will be useful to get familiar with the number of several indexes regarding blood perfusion. The original cerebral metabolic rate of oxygen is acquired by multiplying the original cerebral blood flow and the partial pressure of oxygen and the oxygen extraction rate. It's usually different among the brain tissues of the brain, about 0.4 to 5 in the gray matter, and sometimes increases in, paradoxically, in hypoperfused tissues, maybe up to 0.7. The original cerebral metabolic rate of glucose differs also between the white and the gray matter. The whole brain uses about 4 milligrams per 100 grams of normal brain tissue per minute, while the cortex has higher metabolic rates, about 8 milligrams per 100 grams of tissue in a minute. The original cerebral blood flow also differs in diverse brain areas. while the global brain has about 55 milliliters of blood flow per 100 gram of brain tissue in a minute. The gray matter has a higher value, about 80 milliliters per minute, while the white matter has only about 20 or maybe 30 milliliters. This value differs in between patients, especially by age, but however, these values have been used in previous studies with perfusion spec in order to semi-quantify the blood flow in an area of interest by calculating the uptakes to a reference tissue. Previously, using a fixed value, maybe the cerebellum most likely. In order to interpret perfusion images, it is important to know the perfusion supplied by different cerebral arteries in order to communicate with other clinicians. The ACA and the MCA originates from the internal carotid artery, while the ACA, MCA, and also the PCAs communicate in the circle of Willis by the anterior communicating artery and the posterior communicating artery. Vertebral arteries on each side here join to the basilar artery, which goes up to the posterior cerebral arteries. The cerebellar arteries originate from either the vertebral arteries or the basilar arteries. In gross, the brain circulation can be classified as the anterior circulation and also the posterior circulation. Anterior circulation includes blood supplies from the ACA, MCA, and the anterior choroidal artery, which originates from the tip of the ICA. Posterior circulation includes blood supplies from the PCA, posterior inferior cerebellar, anterior inferior cerebellar, and superior cerebellar arteries, which originates from the vertebral or basilar arteries. Sorry. 화면 지금 보이시죠?
네, 지금 다시 보입니다.
네. I will look into the three major cerebral arteries, the ACA, MCA, and PCA. ACA has 4 to 5 segments, which can be anatomically defined by its branches and structures, as you see in the right upper section. The A1 segment extends from the internal carotid artery, the origin, bifurcation to the anterior communicating artery, which forms the circle of the Willis. A2 extends to the junction of the rostrum and genu of the corpus callosum, which is defined by the anatomic structures of the brain itself. And A3 arteries extends to the bend of the genu of the corpus callosum. And A5 and X5 extends posteriorly above the callosal body and superior portion of the brain, splenium, which is inferior to the posterior cingulate. The ACA mostly supplies the medial frontal and parietal cortexes, but some medial lenticulosteroid arteries also come from the ACA, which supplies the deep structures, meaning the internal structures such as the caudate and the internal capsule, which might also mean that the ACA structures also can affect the patient's movement. However, the clinical meaning of the division of ACA into branches are rather small compared with MCA, but ACA supplies is especially important also maybe for cognitive developments in pediatrics. Compared with the ACA and PCA, the MCA branches may be necessary to remember. And you might have seen these terms reported on angiograms or TFCs in ischemic patients. The M1 artery, which is the main original branch of the MCA, give also rise to the medial lenticular arteries, which also supplies the globus pallidus and the thalamus here, which also can be divided into the medial and lateral lenticular arteries, according to the anatomical position. M2 artery is curved branch in the sylvian fissure, and the M3 goes upward, supplying the cortical segments. MCA usually supplies the lateral frontal, parietal, and temporal cortexes, and you can also remember all of that small branches here. The lenticular artery supplies the inner structures I told you, the globus pallidus and the putamen. PCA originates from not the ICs, but the basilar arteries, as seen on the previous slides. Main branches are the posterior communicating arteries, and also the medial and lateral posterior choroidal arteries. And here you can see in the P2 and P3 divisions. It usually supplies the occipital lobes and the posterior medial temporal lobes, meaning that the PCA also has some supply to the temporal lobes also. The choroidal arteries here also supply some of the deep structures, such as the choroidal plexus and the internal capsule, and also the striatum, meaning the caudate campus, and also some portion of the substantia nigra. This is the summary of arterial distribution of blood supply. What is you can remember is the color distribution of each arteries here. Maybe this can help you when you interpret some blood perfusion specs. The ACA, MCA, and PCA are colored in different, are illustrated in different colors. And as you can see, the MCA supplies the largest part of the cerebral cortex, but the deep structures are supplied by the branches of the ACA, MCA, and PCA, and has a quite rather complicated supply. Branches from the, in summary also, branches from the vertebral and basilar arteries supply the maybe the pontine arteries supply the medulla and pons and cerebellar arteries. And also in short, again, enterochoroidal arteries from the MCA and lenticular striate arteries from the ACA and MCA. Also you can remember. This is a comparative overview of perfusion imaging techniques. Other than PET and SPECT, which are nuclear medicine modalities, among others, maybe many others have been used, but nowadays not much in clinics. Maybe some perfusion CTs or perfusion MRs. Perfusion SPECT is the most conventional method in nuclear medicine, and perfusion CT and MRI are also the most commonly approachable methods in radiology sections. While SPECT uses cerebral blood flow as the main parameters, perfusion CTs or MRI use several other parameters such as cerebral blood flow, blood volume, mean transit time, and time to peak parameters. though the acquisition method is quite different. I think you may have heard about the medical model, the Katie-Schmidt model, which cerebral blood flow is usually used to measure by, which is a single tissue compartment model standard method for analyzing regional cerebral blood flow based on the old Fick principle. Two types of radiopharmaceuticals are mostly used for measuring the cerebral perfusion. Mostly the HMPAO and ECD. I think this might differ in between hospitals. Previously, an iodine labeled iodine 123 IMP also has been used in the early days, but usually most days we use technetium labeled HMPAO or ECDs. HMPAO comes in the name of Ceratec, and ECD comes in the name of Neurolite. They have quite different characteristics, which also affects perfusion images. The time to maximum uptake is quite a bit longer in ECD, about 2 to 5 minutes, and shorter for HMPAO, about 2 minutes. Also, there is a difference in the first pass extraction into the tissues, the target tissues. Higher for HMPAO, about a little less than 80%, and at about 60% for ECDs. The time to maximum uptake is a bit longer in ECD. And percent uptake to the injected dose is about higher, maybe up to 7% in ECD. HMPAO is known to bind to plasma proteins, and the mechanism of the uptakes is differ between the two agents. HMPAO, glutathione is responsible for the mechanism of uptake. Glutathione, which is an reducing agent present in the CNS, has been directly implicated to be responsible for the conversion of HMPAO, leading to neuron uptakes. ECD undergoes an enzymatic deesterification by the esterase activity. After it's inside the cell, it forms polar metabolites, then unable to make it cross the cell membrane. So HMPAO shows initial back diffusion in the first about 15 minutes after the initial uptake, but rather shows stable uptake in the tissue, while ECD does not have any initial back diffusion, but shows a certain elimination in the brain slowly. However, in certain terms, the ECD has a faster elimination from the blood, resulting in higher contrast of the tissue to background activity compared to HMPAO. This is the time expression curve of the three radiopharmaceuticals. I have mentioned to you about iodine 123 IMP. We usually use HMPAO and ECD. As I told you, HMPAO has an initial back diffusion from the brain tissue, but shows stable uptake rate over time. ECD does not have any initial back diffusion, but is slowly eliminated, but the elimination is faster in the background tissue, so the target to background ratio improves over time. The known radiostability of technetium labeled ECD is known to be superior to technetium labeled HMP. HMPO. Also for HMPO, and stabilizers are added, this allows an about 3 to 4 hours of shelf life, meaning after the manufacturing of technetium HMPO, the time between the injection could be about 3 to 4 hours. Once across the BBB, I told you that it's trapped inside the cell. However, usually the recommendation for the acquisition time is about 20 to maybe about 2 hours. For ECD, it has a more quite stabilized status compared with HMPO, and theoretically it is told to be stable of over maybe up to 6 hours after preparation. It has a higher blood clearance compared with HMPO, resulting in a better brain to background ratio. After about an hour after injection, it is known that less than 5% of HMPO remains in the blood. Resulting in a better background ratio. This is a comparison of the normal brain uptakes between the two radiopharmaceuticals. The picture you see here is where the red scales mean that the ECD shows higher uptake compared with HMPO, and the lower here, the blue scales means the regions that HMPO has higher uptakes compared with ECD. ECD shows higher uptakes in some frontal parietal cortex and occipital cortexes, and the superior region of the cerebellum. And HMPO has some higher uptake in the medial temporal lobes and some thalamus and paraventricular white matter, and also some portions in the brainstem here. The acquisition protocol differs in every hospital, so also differs according to what kind of gamma cameras you use. In our hospital, we use ECD as the primary agent and HMPO as a backup agent. Theoretically, as I told you, HMPO can be injected maybe 2 to 3 hours after manufacture with stabilization protocols, and up to 6 hours for ECD, which you can keep into mind when you prepare these radiopharmaceuticals for before you inject into ictal patients, seizure patients for ictal perfusion. Low energy, high resolution collimators or fan beam collimators are used, while fan beams seem to be more popular for image qualities. Previously in our hospital, we used to use triple head gamma cameras for brain images dedicated, but since there aren't any commercial available triple head cameras now, we use two-headed specs with fan beam collimators. The attenuation correction also differs by hospitals, but the Chang's method has been a very old conventional method for attenuation correction, which assumes the brain as one compartment with homogeneous attenuation. So the count correlation for the deep structures may be a bit poor. Other filters, such as low-pass filters, such as Butterworth or Henning, can be used. This is an example of a normal perfusion image for HMPO. The highest uptakes is usually the primary visual cortex in the back areas, and the cerebellum is also seldomly used as the reference region between the basal and Diamox scans. The normal distribution of the maybe frontal cortex is also different by age, also in the young pediatrics and in the older ages with brain atrophies or neurodegenerative changes. Usually the perfusion spect has been studied over 20 years, and many articles has reported about its sensitivity and specificity in different diseases, but mostly the specificity is rather lower compared with the sensitivity in perfusion spect images in different pathologies. However, the tracer uptake patterns also differs in between many diseases, and what we are seeing on the images is the perfusion itself, so we have to interpret what the findings can mean. Usually the code uptakes is rather more easier to read on the images, which can be usually caused mostly by necrosis due to old infarcts, but also by aberrant CSF or edemas caused by other causes, or maybe some space-occupied lesions without no perfusion, such as some hemorrhages or post-OP findings or some AV malformation lesions. The decreased uptake is what we are easily trying to find, perfusion ischemias, and some regions with decreased metabolism, decreased FDG uptake, which has perfusion metabolism couplings, can also show decreased uptake of the perfusion images, showing degeneration or some differentiation of the neurons. Atrophies also show decreased uptakes. So sometimes we have to correlate with anatomical images. Seldomly we see increased perfusion uptakes. I think the most common cause for us to see is the luxury perfusions, and sometimes encephalitis with increased inflammation of the brain cortexes also can show quite slightly increased perfusions. So when I'll talk about the ischemic stroke, there are three etiologies of stroke: the large artery origins, and there may be smaller vessel or lacunar infarcts associated with focal areas of ischemia, to single small vessels, usually in the deep penetrating arteries that I have showed you in the earlier slides, and also cardioembolic infarctions, which has embolic infarct of other sources, maybe from the heart or other regions of organs. Affected regions with cerebral blood flow of lower than maybe 10, maybe less than 20 milliliters per 100 grams of tissue per minute are referred to be the core region of the ischemia. The tissue in the core of the stroke lesion is presumed to die within minutes of stroke onset, regardless of the etiologies of stroke. Therefore, so in acute phases, it may be quite practically difficult to take perfusion spect images during the acute phase due to the acquisition time of SPECT. What we usually want to find in the ischemic stroke is maybe the margin or region of the perfusion decrease, because the anatomical images we see on the MRIs may be quite different with the region of the perfusion decreased areas. Also, we are trying to find which maybe we call penumbras, which can remain viable for after stroke. So what we can decide to treat the patient with. Also, other than stroke, TIA, transient ischemic attack, is a temporary period of symptoms similar to those of stroke, while TIA usually only lasts for minutes, and compared with ischemic stroke doesn't cause any permanent damages. The patient showed these kind of symptoms, which has lasted only about a few minutes or maybe seldomly, commonly up to a few hours, but usually the patient symptoms resolve within 24 hours. According to which period of time we take the images, the MR or other conventional images may not show any specific abnormal findings in TIA. So what we are trying to find in perfusion SPECT is abnormally decreased perfusion areas, and to predict subsequent stroke, which is the most undesirable result we want from TIA. Also, in patients with SPECT perfusion taken in TIA showed at least who showed at least 70% uptake had no evidence of persisting neurologic deficits, which we worry is about subsequent stroke. Another issue we are trying to find in cerebral perfusion imaging is the viability of the brain tissues. Penumbra is the area surrounding an ischemic event. Immediately following the ischemic event, blood flow is decreased, and therefore the oxygen transport is reduced locally, leading to hypoxia of cells near not only the core itself, but also near the location of the original insultion. This can lead to hypoxic cell death, infarction, and amplify the original damage from the ischemia. Technically, in brain perfusion SPECTs, it is hard to identify penumbra since time elapses after the onset of the stroke. The extent of the penumbra tends to decrease, and usually brain perfusion SPECT in clinics for practical reasons are not taken in situations such as acute or subacute phases. But however, brain perfusion SPECT can aid in guiding the region of the insulted area compared with the anatomical images. The upper row here is an example of an infarcted brain with decreased cerebral blood flow here, with decreased oxygen metabolism and decreased oxygen extraction fractions. After reperfusion therapies, you can see that the upper row did not show any improvement in the oxygen extraction fraction. But however, in the lower row, which is presumed to be penumbra here, the cerebral blood flow is decreased compared with the upper row, which shows a defect. Oxygen metabolism is decreased, but not zero here, while it shows an increased oxygen extraction fractions. After reperfusion, the oxygen extraction fraction was returned to normal. So though the perfusion is decreased here, this includes the region of the penumbra itself. So this may be an importance in finding the perfusion decreased lesion, and not only the ischemic core and neuronal cell death lesions shown on MRIs. This is a slide, however, this is a slide showing the relationship between blood flow and neuronal viability. To understand the relationship between low perfusion areas and neuronal viabilities that can differ penumbra. The above picture showing the electrical evoked potential, meaning the electrical signals of a neuron. When the blood flow here decreases, showing the upper row is the evoked potential, meaning the neuronal cell viabilities. When the blood flow decreases gradually, evoked potentials were abolished. Evoked potentials were not found on the perfusion of about 15 to 20 milliliters per 100 grams per minute of blood flow, meaning that this might be the threshold for neuronal cell death. However, spontaneous activities were a little bit seen, up to maybe 20 milliliters per 100 grams per minute. However, individual neurons itself show a large variability, ranging from maybe 10 up to maybe 20. The lower picture here shows the time course and the decreased cerebral blood flow, and showing the result of the time and decreased blood flow. Also, a decrease in perfusion below the penumbral threshold, maybe I told you about between 15 to 20, manifests as a neurologic deficit. The progression to irreversible infarction stage depends on the interaction between the duration itself and the severability of decreased perfusion. So it might not be always a clear cut in reference to infarction time or blood flow, but you can maybe just remember the rough time of the ischemia insult and perfusion flow. However, it has usually been known that when we try to do reperfusion therapies to a patient, it should be less than an hour or 30 minutes. And depending on the blood flow, the time can be more shorter, which might lead to only just some neuronal cell necrosis or infarction of the whole affected regions. This is a famous picture showing the hypoperfusion related mechanisms of a person who undergoes ischemia. What we see on cerebral blood flow images is the third picture showing here the cerebral blood flow, which decreases. However, before the decrease of the cerebral blood flow, our brain undergoes some certain compensative mechanisms with regarding the cerebral blood volume or oxygen extraction fractions. When an artery gets narrowed or has been affected by some kind of reason, cerebral perfusion pressure decreases. The cerebral perfusion pressure decreases, our body goes into some kind of a compensative mechanisms by increasing the cerebral blood volume by vasodilation. That is to maintain the cerebral blood flow. So, in short, to maintain the cerebral blood flow, the cerebral blood volume increases to compensate the decreased cerebral perfusion pressure. However, since the vasodilative effect cannot go in a limitless way, it comes into a certain limit, and from that point, the cerebral blood volume cannot increase more, so the flow decreases from that point. From this point, our brain tissue also goes into some kind of compensation by increasing the oxygen extraction fraction in this way to maintain the metabolic rate of oxygen our brain uses. However, the oxygen extraction fraction cannot undergo a limitless increase also. So from when the oxygen extraction fraction comes to its limit, the metabolic rate of oxygen from that time starts to decrease. So what we are seeing right now here is the decrease of oxygen metabolism, meaning from this point, the neuronal cell becomes dead and we see high signal or low signals on MRI. So the signal changes we see on MRI starts from this point, but we are trying to see the decreased cerebral blood flow before the insertion of neurons, which we see on anatomical images. Also, I will show you later, we use Diamox intervention to see the course of the disease before the decrease of basal cerebral blood flows. Diamox is frequently used when acquiring blood perfusion SPECT images. Acetazolamide, Diamox, inhibits H2CO3 being dissolved to carbon dioxide and H2O and induces cerebral carbonic acidosis, resulting in vascular dilatation. It is known that Diamox induces about 30% of increased blood flow. So we acquire two images, one without Diamox, we call it resting or basal perfusion, and one with injection of a Diamox, which we call Diamox scans. So what we are trying to see with Diamox is the course before the decrease of cerebral blood flow, trying to see the degree of compensation, meaning the vasodilation of the brain to compensate the decreased cerebral perfusion pressure. Usually we divide the response to Diamox into three categories. One is the normal response in the upper row here. The image with the Diamox has higher absolute blood flow, but in clinical situations, when we interpret images, we use the same degree of color scales between the basal and Diamox for convenience. But however, the absolute blood flow is higher in this Diamox scan compared with the basal perfusion scan. When the patients show decreased basal flow, but no differences between the affected and non-affected area, meaning that the Diamox scan shows increased flow of the also in the affected areas, meaning sometimes the patient may have good collateral flow to the affected area despite the decreased basal flow, or maybe some decreased blood flow of the basal status due to other causes of ischemia, such as neurodegenerative diseases. The third one we are trying to find is the decreased reserve, usually seen in ischemic diseases. The decreased perfusion pressure, meaning here in the Diamox scan, is that the patient already has undergone its compensation of increasing the blood volume to its limit. So even though we give Diamox, the Diamox does not affect the area of the ischemia because the vasodilation has already gone to its maximal capacity. And when we give Diamox, the vessels do not have any residual capacity to increase blood flow. So in this case, the contrast between the normal and the affected lesions between the two areas becomes higher. I have told you that we use the same scales between the resting and the Diamox scan in the basal images. Also, it is same for the images on the row 3 here. So on the normal images, even though the color scales are when you look at it, it might be same, but the normal hemisphere is receiving more absolute perfusion when we give Diamox. So that is the reason for the higher contrast of the two affected regions after giving Diamox. So in short, in a graph, the normal type of response is seen in normal patients. And when we say the response to Diamox is normal, we usually say the vascular reserve is preserved, meaning that there are still remnant capacity of normal blood vessels to vasodilate. When there seems to be no differences of two affected region, when there seems to be no differences between the affected region and the non-affected region after giving Diamox, type 2 is when the patient has ischemic diseases, but also have good collaterals to the affected areas, which we sometimes see in patients with chronic status or some MMD patients with only mild symptoms. The decreased Diamox response we see usually in patients with ischemic diseases with poor collateral supplies. We also sometimes see increased perfusion in ischemic patients, which we refer to as hyperperfusion syndromes or luxury perfusions. Hyperperfusion are not actually functioning perfusion that are supplied to the infarcted brain. So this does not represent true perfusion to the brain. The mechanism explained for this is the impairment of autoregulation. In short, by increased intravascular pressure resulting in depolarization of the vascular smooth muscles or some vasoconstrictions at high systemic blood pressures. When the blood pressure goes high, when the high blood pressure exceeds the normal limit we can maintain, it affects the myogenic autoregulation, and the remaining autoregulation in the arteries is depend on the sympathetic autonomic innervations of the vascular smooth muscles, resulting in transudation of fluid to the, maybe not the neuronal cells, but main neurons, but the pericapillary astrocytes, causing sometimes some vasogenic edema. And when we look at this pathologically, we sometimes see hyperplasia of the endothelial cells and some fibrinoid necrosis and extravasations in breakthrough of the hemorrhages. So as I told you in the first place, this kind of hyperperfusion is not true representative perfusion to the brains. The hyperperfusion syndrome also can have various types of symptoms, which in most common ones are deteriorations of conscious, maybe some headaches, sometimes it causes seizures, and sometimes it causes motor disturbances. And now coming back to the Diamox scans, which I told you that we are trying to find the vascular reserve, has these kind of indications in the clinics. Sometimes we only perform basal scans, but when we usually try to assess the patients with ischemia, we usually undergo Diamox scans because it improves the diagnostic sensitivity of cerebral vascular diseases. This can be explained by the fact that the basal scan only shows you the cerebral blood flows, but when we use the Diamox for intervention, we can see the pathological course before the decrease of cerebral blood flow by seeing the degree of compensation of decreased cerebral perfusion flow. So we see different extents of affected areas. So it has more merits in evaluating the ischemic extents. Not only before the evaluation of bypass surgeries, but also other treatments can be evaluated before and after the treatment, such as carotid and arterectomy, or just stenting. Another main indication is the diagnosis of MMD patients and evaluating the patient's symptoms, and before operation deciding which side or maybe how much extent we would perform the surgery in MMD patients, and also for following up after the surgeries. This is one of the first prospective studies for evaluating patients with cerebral ischemia with Diamox scans to see the long-term prognosis of treated patients with ICA or MCA stenosis or occlusions. Patients with decreased cerebral reserve had a higher possibilities of developing ipsilateral stroke here or total stroke here compared with the patients without any decreased cerebral vascular reserves. This was one of the first articles published in 2001 showing that the Diamox scan can be used in predicting the prognosis of stroke patients. As I told you, the Diamox scans can also be used to evaluate the patients who are to or who underwent carotid endarterectomy or stenting. Carotid endarterectomy or stenting is usually indicated for patients with one or more TIA events or patients who have carotid and carotid artery stenosis exceeding maybe 50 to 70%, because those patients has a high future possibilities of developing future infarct events. It may be used. This may be used for patient with ipsilateral TIA or carotid artery stenosis, or also for maybe combined with patients who are high to develop future events. So before we treat those patients with either endarterectomy or stenting, patients who undergo Diamox scans can be evaluated with the degree of cerebral vascular reserve decrease. In this case, in this article, the authors used indication of CVRI, which means the Cerebral Vascular Reserve Index. This is the percent amount of increased blood flow after Diamox compared with the basal scans, shown in percentages. This case here is an example of patient with proximal MCA stenosis. After stenting, you can see the anatomical blood supply has been recovered to normal. Before stenting, we see a wide broadened region of decreased cerebral vascular reserve, but after stenting, we see that the decreased vascular reserve extent has become very small. As I told you also, it is usually widely used for moya-moya diseases. I think you are probably familiar with MMD, but MMD, in short explanation, is characterized by bilateral stenosis or occlusion of the distal internal carotid arteries, and including its branches, including the ACA or MMDs, ACA or MCAs. The only treatment for MMD is surgeries, which we supply decreased regions with other arteries or anatomical regions. The surgery method can be divided into direct method or indirect methods. The direct method is usually supplied by the superficial temporal artery to the MCA regions directly. Indirect method are rather slightly more complicated compared with the direct anastomosis, and is also known to be technically a little more difficult. There are several types of anatomical methods for indirect anastomosis. EDAS, which is shortage for encephalodiural arterial synangiosis, is supplying the dura to the making a flap to the region with a decreased blood flow and to induce collateral flows. However, there are also another method for indirect supply, the EGS method. This is not only supplying the dural arterial synangiosis, but also the EGS method is gallio periosteal flap inserted to the cortex. This EGS method is usually used to supply the frontal cortex for the development of cognitive functions, especially in pediatrics. So according to the patient's age or which hemisphere, we select which kind of operation the patient would receive. And what we want to see in cerebral perfusion images is the extent of the decrease of perfusion, not only in the MCA areas, but also in the SCA areas, for especially in pediatrics, to predict the benefits of surgery the patient would receive. When the pediatrics receive this kind of an indirect surgeries, for example, if he or she received bilateral surgeries, he or she would receive one time EDAS combined with EGS, and the next time EDAS only. So not only for stenting or endarterectomies, but also for MMDs, many people have studied the value of prediction of a perfusion spec. This is an example of perfusion spec evaluating the clinical outcomes of MMD operation. The above picture here shows an example of a patient with improved collateral flow of decreased frontal and left hemisphere after receiving surgeries. Also, you can see improved collateral after surgery here. And lower case is an example of a patient with a poorly different collateral flow after surgery, with no significant improved vascular reserve seen on the right hemisphere here. You can also see no significant improvement of collateral on the TFC here. We also can quantify the results of the surgery, and the improvement of cerebral vascular index also correlated well with the clinical outcomes in these MMD patients. And not only for MCA or anastomosis, the pediatrics also, I told you, has some issue in the front improvement of frontal cortex. The ST-MCA anastomosis is very difficult in children younger than maybe 2 years of age, and sometimes the TFC also might be a little bit hard for very small aged patients. And in this case, the EGS or EGS flap is used to supply the frontal cortex, as I have told you, to maintain the development of cognitive functions. Perfusion spec here, who received EGPS here, showed improvement of frontal cortex reserve compared with the preoperative and postoperative images. When we use those kind of cerebrovascular reserve indexes, we usually use SPM programs to use probabilistic maps, anatomical mapping to confine the regions we are of interest. Those previous studies I have showed you used the probability map of cerebral perfusion of different regions. One of the earliest regions, earliest maps was made by injecting radiopharmaceuticals to the patient's MCA arteries directly when the patient was undergoing TFC. After TFC, the patient came to our department to acquire perfusion specs, and by generating a probability map of the perfusion spec images using anatomical normalizations, we generated MCA templates. Also, for just your just for explanations, recently many other sequences of MRI have been come to use in evaluating the cerebral perfusion, and recently has taken some roles over perfusion spec due to its convenience and ability to evaluate anatomical abnormalities also. The FLAIR images show P2 prolongation images while suppressing the fluid signals, that is to clearly reveal regions proximal to the CSF or maybe some cerebral cortical regions. The gradient echo shows some hemorrhages here, and diffusion DWI or ADC maps show here acute regions. The perfusion also has been evaluated in MR images by using different parameters such as the cerebral blood flow, blood volume, mean transit time, time to peak images. However, as I told you in the early slides, the acquisition protocols are quite different between the perfusion spec images. The perfusion CT also measures blood flow, blood volume, MTT, and TTP images, and also have been studied to evaluate the perfusion status and the region of penumbra. As I remember, it was most widely studied in the early 2000s, and however, perfusion CT also has some limitations in setting the input function and setting the ROIs. When the indexes were compared with SPECT or PET images, however, images were more stringent in PET images. However, in conclusion, still perfusion SPECT also has its strength in measuring perfusion and more accurate quantification. But however, in some clinical limitations, the acquisition time has certain indications, limited indications. So rather compared to other subjects of nuclear medicine, this part has not that been widely studied since. Before I go on to the next topic, can I take a 5-minute break?
Yes, I think we can have like, if it's okay, 10-minute break, and then we can move on to the epilepsy. And in between the lectures, if you have any questions or comments, just would you freely write down or give us some questions in the chat. Yeah. Then let's meet 10 minutes later. It seems there are some questions regarding the perfusion aspect. Professor Song, could you answer some questions in the chat for us? 선생님 목소리가 안 들리네요.
들리시나요?
네, 잘 들립니다.
Okay. The first, maybe, is there any pitfall for Diamox scan? This can be a easy or a hard question. Pitfall. The perfusion uptakes we see on the scan itself may be not only just cerebral perfusions, as I told you in the previous slides, but also be due to several other etiologies. That is very variable, meaning that only when we consider the functional images that we have limitations in interpreting the images. So I think that it would be important to us to see what kind of situation the patient is in, and to maybe consider other anatomical images to exclude unwanted interpretations that we want to make of the decreased perfusions. And, IMP, someone asked about IMP, HMPO, and ECD. For our experience, IMP, I have not used IMP because I'm not that far generation, and in our department we usually use HMPO and ECD. However, comparing those two agents, in our experience, we think that ECD has kind of a little better background to target ratio compared to HMPO, and maybe a little better image quality, and the stability of the ECD also may be a factor, but when we use it for ictal specs, maybe I'll show you in the further slide that it might be different. So in our department, we usually use HMPO and ECD both, but ischemic patients, we usually use ECD. And HMPO are discussed in later. And this is also a difficult question, asking about the ASL MRI for evaluating perfusion. Do you think brain SPECT can survive? To be honest with you, in our department, in our hospital, the volume of perfusion SPECT has decreased gradually compared with other PET images, while they have been increasing in a whole lot volume. Even though the patient number has been increased in our hospital, the volume of perfusion SPECT images has been decreased. For nowadays compared with previous days. That may be because of I think the clinicians have some kind of found their merits in not only evaluating, not only for ASL images, but other options that MRIs can offer and other methods, other sequences for differentiating other diseases. However, I think that brain perfusion SPECT may also have some merits in quantifying the exact amount of perfusion compared with the other MRI techniques. And from now on, I think it still has its power in following up the patient, usually in nowadays clinics. So in short, it has been overcome by other methods in the diagnosis or initial evaluation by other MRI imaging, but I think it may have some still meanings in following up because the perfusion quantification may be quite precise. So I'll go on with the second topic for today. The next topic is about epilepsy. Epilepsy is a group of neurological disorders characterized by recurrent epileptic seizures. The underlying mechanism is explained by many factors. It is known to result in abnormal neural activity of the cortex in the brain. The reason this occurs in most cases is not mainly known, but some occurs as the result of brain injury, stroke, brain tumors, infections of the brain, or birth defects, or maybe sometimes genetically. For the purpose of imaging in seizures, we try to find the focus of the seizure, maybe lateralizations, and usually the perfusion SPECT or sometimes the FDG PET has been most widely used, showing about sensitivity about maybe over 80%, depending on what type of seizures, maybe a little higher in temporal epilepsies or maybe lower in other types. And what we are trying to find is the different among the purpose. Maybe we are trying to find the epileptogenic lesion itself, but usually we are trying to find the lateralization hemisphere. Other than EEG studies, the clinician use many options, including MRI and PET and SPECT. And it has been used for a long time for the evaluation of epilepsy. MRI itself is well known to show sclerosis of the medial temporal lobe, but however, since it has a limitation in showing the neuronal activities itself, it fails to reveal apparent abnormalities in about maybe 20 or up to 40% of the patients, depending on the region of the epilepsy. FDG PET is thought to have a higher sensitivity in localizing the epileptogenic focus and can provide information complementary to other brain MRs or EEGs in pre-surgical evaluations. Ictal SPECT also has its role, and when we perform perfusion SPECTs, we perform ictal SPECTs by injecting the radiopharmaceutical to the patient quickly when the patient shows seizures. And also we can look into basal interectal specs. And FDG PET findings, we usually try to find possible decreased metabolic activity, hypometabolic focus, which could be subjective for the epileptogenic lesion. Ictal specs, on the contrary, show hyperperfusion, increased perfusion of the lateralized size or seizure focus. And sometimes, depending on the spread of the neuronal signals, we see more wider, broadened areas of increased perfusions. For ictal spec, which is the acquisition of perfusion images during seizure, it is taken by quickly injecting the radiation source to the patient while the patient is in seizure. The quick injection is the most important part, and usually we prepare the radiopharmaceutical by the patient in a room which we can monitor whether the patient undergoes or not undergoes the seizure. And the patient has some kind of prodromal symptoms and thinks that he might undergo seizure. He presses a button, and from the station we can see that the patient has gave us a signal, and we quickly go inside the patient's room, and when the patient is undergoing seizure, we quickly inject the source. After the patient finishes his seizure, the patient comes to the nuclear medicine department and undergoes image acquisition. While the patient does not undergo seizure when he or she is taking the image, though since the radiopharmaceutical itself was injected during the activity of seizure, and as I have shown you in the previous slide, the radiopharmaceuticals are stabilized in the brain. Therefore, we can acquire ictal images in our department while the patient is not undergoing any types of seizure when he or she is lying on the camera. Also, the interpretation of ictal spec images should always be done in the context of full pre-surgical evaluation. The injection time should also be known when we interpret images, because early injection gives us the best results, and as a rather slow inject, we can presume that the perfusion spec would have been taken after some propagations of the signals. Syscom images has been used previously, which is mean by a subtraction of interictal from ictal spec images. That is, we take both interictal and ictal spec images and subtract the two images to find the focus of accurate anatomic localization of the ictal focus. In this case, when we use Syscom images and both basal and when we use both ictal and interictal images, some say that the sensitivity could be up to maybe 80 or 90% for temporal lobe epilepsies and about 70% for other types of neocortical epilepsies. The overall sensitivity is reported to be tended to be lower for extratemporal lobe epilepsies. For perfusion spec, when we inject into the patient's arm, it takes about 20 to 30 seconds for the tracer to reach the brain. It is known that the ictal post-ictal switch, I mean the switch from ictal hyperperfusion to post-ictal hypoperfusion state, occurs in maybe in longest 2 minutes after the onset of seizure, but it is known to be shorter in extratemporal seizures. It has been estimated that in extratemporal seizures, the injection should be given in about less than 20 minutes. The case here, you see the injection was given after 25 seconds after the seizure onset. And it has already shown some propagation of the signals. Figure E is the ictal hyperperfusion, and the Syscom images acquire compared with the basal scans. When we give higher threshold, the focus is localized to the left temporal, but when we lower the threshold of the Syscom images, we can see the propagation spread into other cortical areas from the temporal lobes. So the most important part of acquiring images is the time of the injection, and it is usually recommended to be lower than at least 20 or 30 seconds, considering the time that takes for the tracer to reach the brain and the time for the switch from the ictal to the post-ictal status of the patient. Also, repeated image acquisitions were known to have a higher sensitivity for the lateralization and the localization of the patient's focus, since the seizure itself may be different every time respectively of the patient. And the more you take, the more you are likely to have image with a shorter time interval of injection. However, in clinical practice, I told you that the clinicians also look into EEGs, MRIs, SPECTs, and sometimes PETs, but the preoperative studies are not always concordant among different study modalities. And many studies have shown many different sensitivities among studies and the combinations of studies. However, in short, that the sensitivity is somewhat a little bit higher for temporal lobe epilepsies, considering about up to 70% of sensitivity, and maybe somewhat lower for extratemporal lobe epilepsies, in between 60%. And when we consider many study image modalities, the sensitivity becomes higher. However, the perfusion SPECT and PET definitely is known to have a role when MRIs or EEG cannot localize or lateralize the cause of the perfusion. In this article here, HMPO and ECDs were compared for their sensitivities in localizing the epileptic zone. This was published about almost 20 years ago, but however has been referred to much afterwards. And in this article, according to this article, HMPO showed better performance. HMPO is known to reflect tissue perfusion, but ECD reflects both the perfusion and its enzymatic activity, the metabolism. If when you consider these differences, HMPO might be more likely to reveal hyperperfusion areas in the epileptic zones, but not for ECD. However, the mechanism may be not that clear, but in this case, late washout of ECD was not the possible cause of this type of differentiation. So in comparing HCD and HMPOs, ECD might have a better background to target ratio and maybe a better image quality for imaging ischemia, but in HMPO, it has been conventionally recommended to use HMPO more. However, you should also consider the shelf life and stability of the HMPO. And when you give the radiopharmaceutical to the inpatient clinic, you have to consider when you make the HMPO. And if the patient does not undergo seizure for a certain time, you may have to reproduce the HMPO and give them a new source quickly. So there are many other factors that you can consider according to your clinic's situation. This case is of a 30-year-old man with complex left partial seizure, showing false negative findings in the MRI, but ictal activity was shown in the left mesial, temporal, and lateral cortexes. FDG also can show hypometabolism in the left temporal lobes. Some studies demonstrate that SPECT with CISCOM, as I shown you, showed ictal hyperperfusion, but less frequently compared with PET hypometabolism, meaning that FDG PET may be more sensitive for temporal lobe epilepsies compared with SPECTs, according to some studies. However, when both FDG PET and ictal SPECTs are have concordant reporting results, the patient had a better preoperative evaluation, which eventually led to better patient's outcomes. Other than FDGs or perfusion SPECTs, several other types of radiopharmaceuticals also have been studied for the evaluation of epilepsies. Among them, GABA has been the most studied target for epilepsy. GABA is the most important inhibitory neurotransmitter in the brain. And two types of GABA receptors, GABA A and B, exist, and benzodiazepine receptors are known to be the modulatory sites of GABA receptors, and the flumazenil, which we use by labeling F18 or previously C11, blocks the benzodiazepine sites on GABA A receptors and thus antagonizing them. F18 or C11 labeled flumazenil has been established as the tracer of choice a long time ago for patients with refractory epilepsies. The above case here is 19-year-old female patient with who had shown bilateral hippocampal sclerosis on MRI. B is FDG PET image, and C is F18 labeled plumazanil image. They both show low temporal mesial uptakes in the left side. However, plumazanil itself has a better contrast compared with FDG. The above case here is a 56-year-old male patient, and on MRI, he had a little bit atrophy on the right hippocampus, and on FDG PET, on the B image, the patient showed a little bit of hypometabolism on both sides, while on the plumazanil image here, you can see the right temporal at a decreased uptake prominently compared with the left side. However, after the first report of plumazanil PET, asymmetry indexes has been varied among many different results, and some reports have reported that when compared to FDG, plumazanil tends to have a less asymmetry uptake compared with between the lesional and the contralateral side. But however, many studies have said in common that the lesion with a decreased uptake had a small cluster size compared with FDG. It means that the plumazanil had a better localization, showing the focus of the decreased uptake compared with FDG. So plumazanil PET had a higher specificity for the localization of the epileptic zone, with showing more restricted abnormality findings compared with FDG. The serotonin receptor also has been implicated to take a role in the pathophysiology of epilepsy. The serotonin 1A receptor has been known to been related by their activation reducing glutamate release and hyperpolarizing the hippocampal membranes. So some investigators found reduced binding in the mesial temporal focus. For serotonin PETs, there are also a lot of radiopharmaceuticals, but the most common ones, maybe you have heard the ones ending with the name of Way, blah, 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 Way, radiopharmaceuticals. And this is a case of patient with a left mesial temporal hippocampus sclerosis and temporal lobe epilepsy. This is an F18 labeled Way PET showing reduced left temporal receptor binding. Also had concordant findings on the EEG images. However, compared with plumazanil PETs, for serotonin PETs, the reduced uptake is usually has been studied particularly in the hippocampus, and they have suggested that when combining these serotonin images with other kinds of images, it would be useful in predicting the outcomes for especially temporal lobe epilepsies, and to whether or not to perform temporal lobectomy for the treatment. Another radiopharmaceutical that has been recently studied for epilepsy is the TSPO, targeting the neuroinflammation. It is not that quite familiar compared with other benzodiazepine or other receptors, but however has been recently studied not only in epilepsies, but also in many neurodegenerative diseases. However, there are some limitations of TSPO ligand uptakes due to each patient's normal genetic polymorphisms of TSPO. And still there are many different radioligands, meaning that there is not one breakthrough radioligand for imaging TSPO. However, it has been studied very much, and TSPO itself is mitochondrial membrane protein, however, known to take part in neuroinflammation and is known to markedly increase in reactive microglial activities in response to injuries or any neurodegenerative diseases in the CNS. The benefits of TSPO images on the evaluation of epilepsy also have been studied for a while, but yet results are preliminary, as in TSPO studies in other neurodegenerative diseases such as Alzheimer's, or Parkinson's, or traumatic brain injuries. This picture is an example of a patient with temporal lobe epilepsy with high C11 labeled PBR uptake in the ipsilateral right temporal lobe vision compared with the left temporal lobe. This patient did not show any definite findings on the MRI here, and this is an example of neuroinflammation causing neuroinflammation image showing the seizure focus. However, there are still some limitations in evaluating the neuroinflammation in epilepsy regarding its pathophysiologic link between the neuronal electrical activation and resulting in the neuroinflammation. Other than these previous radiopharmaceuticals I have shown you, there are many radiopharmaceuticals undergoing studies for a long time, but however, there is not one definite radioligand. So, and still the nuclear medicine studies are usually done by taking ICTAR specs and FDG PET specs, and other kind of PET images have not shown any yet definite superiority compared with other previous agents. Okay, this is the end of my presentation, and I would welcome any comments from the audience.
Do any participants have further comments or questions? I think you can just really talk from your mic, or you can write down on the chat.
Okay.
Yeah, I think it clear lecture. So thank you very much again, Professor Yosong Song. And I think we can end up the lecture for today.
Thank you.
Thank you very much.